So we started looking at first the regulations around being able to do Medicaid reimbursement for community-based care, and there was a court case about 10 years ago that allowed for this to take place, and these are the kinds of experimental programs that are starting to pop up in communities designed to keep people in their homes but allow for Medicaid reimbursement. And so that's the second
Does this envision 24-hour care?
The models are very different. In a lot of cases, you don't need 24-hour care, but you do need some, oversight. So, for example, there is a program being run by a doctor up in Maine in rural communities that uses a lot of technology in the home. Some might call it surveillance, but it's technology so that you can check in, you can see, how the individual is making out in the course of the day, and then there are visits with people, that would come to the home.
But it does transfer some of the burden, presumably, onto the family.
That's correct.
Yeah.
That's correct.
Do they get any reimbursement for that, or is that?
Well, the thing that we're looking at, and this is where the Medicaid reimbursement comes in, is that the government is, in recognition that this is less expensive care, is looking at and will allow Medicaid reimbursement for these kinds of in-home services.
What models are in place now for this? Are there in other communities? Have they done this?
They're just starting in other communities. So there's the communities in Maine. The doctor who I apologize, I don't have his name on the tip of my tongue, but has started this type of a model in a number of rural communities in Maine. Not dissimilar to the kind of situation Nantucket has, at least in the off season. There are some programs in urban settings that have started specifically through Johns Hopkins in the Baltimore area that are showing promise, which are people that will come in, they're reimbursed for making modifications in people's homes, and those kinds of things, so that your first response is not to go to an institutional setting, but to see if you can continue.
Clearly, though, you'll need, if that is the model that's to be followed in the future, you're going to need a bunch of people sort of professionals guiding the families as to how to go about this. And
that is correct, and we certainly looked at that, and our initial thought, and this is one to be developed, is that we would think about repurposing our island home staff, or a part of our island home staff, to under the professional supervision of registered nurses and the like, to deliver the care perhaps through our island home. So as you might have less people involved in the institutional care, you'd have more people involved out in the community.
Yeah, but I was thinking that before a family even gets into that mode, you're going to need to have somebody to go to talk to about how to implement it, both in terms of the care itself and in terms of the sort of the facilities.
That's correct. And there are a great deal of a number of social service groups down here. And I know on a personal level that I've dealt with most of them, and there probably is a need for a little bit more integration, so that a family that is totally, is perhaps, flung into this crisis that they're having of what to do with a parent or sibling, there's a good place to go and touch the system so that you're going to get directed in the right fashion. And we've had we didn't really have a lot of discussion about that in our meetings, but I've been to a couple of community events where that's been raised, and there's very clearly a lot of social service groups here on the island, and some recognition that perhaps a little bit better coordination from the consumer side. Right. I think they coordinate very well amongst themselves.
On the delivery side.
But as a consumer coming into the the market, if you let me do that, it's not quite as seamless as it might, as the literature might portray it.
Were there any other options that you looked at?
Well, let me get back to the discussion that we did have about should we close the facility down. And, as you know, our island home is been a long time tradition and a facility that many island residents have utilized over the years with family members. Generally, if you're on the mainland, there's usually a facility within about 25 to 30 miles of where you live. Oftentimes, there are many facilities to choose from. So while there are facilities on the Cape, and they're probably fit within the 25 or 30 mile range, we also have to get on a boat or get on a plane to go and visit. So quite frankly, we concluded that we probably needed to have some skilled nursing options available on Nantucket. And it seemed as like it would be perhaps an unnecessary burden, and certainly one that we actually thought the taxpayers would, getting out of the business, probably would not support. So, but also mindful of the fact that we wanted to see if we could rejigger this financially. That's why we started looking at how do we provide perhaps less institutional care and more aging in place care, for individuals on the island.
So what are the voters going to be asked to do at town meeting? Has that been decided yet?
It has not been decided. I was tasked with sort of leading the next charge, so that's what I'm going to be doing for the next few months, and have a good group of people, obviously, here on the island, but there has been some connections now made with people at the state and some other off-island institutions that are looking very much at this kind of care. So I think that we're going to have at our disposal some good resources, and I hope that we have something that makes a lot of sense to the voters come April or whenever our town meeting is scheduled.
Good. Well, we'll get you back on when we're ready to talk about that next step.
Very good. Be happy to do it.
David Worth, thank you for your service in doing this, and thank you for being with us today.
Pleasure. Thanks, Dan.